Good afternoon to all of you here, all my viewers. Welcome to this post-lunch Saturday afternoon webinar. I hope you're all here after a good meal. It's a great day today, and despite all this COVID, we are grateful to technology that we are all together here today and are able to go ahead with learning and doing what we have to. Let me just start the ball rolling by putting on my screen and sharing it with you all. Just give me a second. So, as I said, this is an afternoon where we are going to discuss an important part of pregnancy. We all know that pregnancy is something that we all desire. It is a natural need of everyone. And whether it is natural or whether it is assisted, we need to understand the role of a very important hormone called progesterone in pregnancy. So we are going to look at the key concerns of pregnancy. And let me introduce just say words about myself. My name is Dr. Sonia Malik, and I'm the HOD and Director of South End Fertility at IVF at Delhi. And you may have seen me many a times in webinars and in conferences, I would say. I have been the past president of the Indian Fertility Society and have been practicing in fertility for the last 40 years and IVF for the last 30 years. So basically, with that little introduction, I take you on to now what we are going to discuss. And basically, our main concern is to discuss the role of progesterone in various stages or states of pregnancy, normal as well as abnormal. And like I said, we started with the role of progesterone in implantation and natural pregnancy, and we are going to take you through with a lot of evidence-based medicine so that we can justify the use of progesterone in pregnancy. So here we start with its role in implantation and pregnancy, and you can see over here in this cartoon or in this image that progesterone is secreted after ovulation takes place and the structure called corpus luteum is formed. The progesterone levels start to rise in the blood, and because of the rising levels of progesterone, there are changes in the endometrium or in the uterus, which transforms from its proliferative phase to the secretory endometrium, which is more juicy, which has a lot of stroma and a lot of vascularization in it. So the changes in the uterus are actually reflecting what is taking place in the ovary. The actions of progesterone, as I told you, are basically the hormonal actions which actually stimulate the growth of the uterus. They stabilize the endometrium, as well as the myometrial contractions, which is a very, very big role that progesterone plays. Right from the beginning of pregnancy up to the end of pregnancy, it inhibits the myometrial contractions and therefore allows the pregnancy to continue. The secretory transformation, like I said, increases the vascularity of the endometrium, and therefore it makes the endometrium more conducive to a continuing pregnancy. Another very important part is the immunomodulation, which means that the immune system is also changed, and it actually causes a difference in the environment of the uterus, and thereby it makes the uterus again more conducive to a pregnancy. So the non-hormonal actions, on the other hand, of progesterone are the immunomodulatory action as well as the uterine relaxant action. That is, that in the immunomodulatory action, what we find is that there is a favorable shift of the immune system from the Th1, which is the inflammatory response, to the non-inflammatory response, which is much more conducive and much more favorable to the continuation of a pregnancy. It also modulates the chemokines, and it inhibits the rejection of the tissues. So that is basically the immunomodulatory effect of progesterone. And along with that, like I mentioned earlier, there is a big uterine relaxant effect which happens, and it blocks the oxytocin like effect of prostaglandin F2 alpha. That means that PGF alpha, that is what we find mostly when there are uterine contractions in the uterus. And along with that, therefore, the contractility of the uterus is absolutely decreased right from the beginning of ovulation till the end of pregnancy. And that is what supports the pregnancy. So basically, we are looking at the various actions, whether they are hormonal or non-hormonal, of progesterone. So these actions, whether it is inducing the proliferation or whether it is preparing the endometrium for the reception of the blastocyst and causing implantation, these are all very, very important for the maintenance of pregnancy, and they are absolutely indispensable. Hence, for the maintenance of pregnancy, the actions of progesterone are critical. The progesterone increases endometrial maturation, it regulates the inflammatory mediators, like I said, and of course stabilizes the endometrium. So, in cases where there is a decreased level of progesterone, you can all understand that if the progesterone levels are therefore not adequate, what is going to happen? All these things are going to get deconnected or actually becoming worse. So what we are going to see here is that there will be more of prostaglandin release. The cellular immune system will be activated and it will become more hostile towards the pregnancy. We are having, instead of the Th2 response, we will start getting the Th1 response. And of course, the blood vessel permeability is also increased. So all in all, the entire endometrium or the uterus itself, not just the endometrium, even the muscular component of the uterus, everything gets upset because of a decreased progesterone level. And this actually helps then to terminate the pregnancy rather than continue the pregnancy. Therefore, progesterone is the most important hormone in order to make the pregnancy continue. So the role of progesterone is therefore critical. And it is not only that the progesterone has to be present, it is also that the correct amount and correct duration of progesterone is critical for the maintenance of pregnancy. It's just that we need to have it in the right amount and the right duration. So what we were talking then about the natural versus the synthetic progesterones, and we know that the natural progesterone which is available to us is in the form of micronized progesterone. This has no effect on mood, on cholesterol and pregnancy outcome, and it may cause some amount of fatigue and sedation, which we try to overcome by different methods. Whereas the synthetic progesterone, on the other hand, can have adverse effects on the mood, HDL cholesterol, as well as pregnancy outcome. The commercial preparations, like I told you, were two, natural as well as synthetic. And in natural, we are talking about micronized, and in the synthetic, majorly about diasteron. The others are all 19-node testosterone derivatives. Hence, they are, and the new progesterones, progestogen, are not to be used in pregnancy. Now, coming back to the how the natural progesterone is formed and how we have changed it into micronized, what have we done to it? Natural progesterone is found from soya beans as well as from the Mexican yam roots, and these have a structure which is very similar to the physiological progesterone. Hence, it is being used in commercial forms. So, in order to make it more safer and more conducive for use, there is this process of micronization which has been done to this progesterone so that it is not absorbed so easily by not absorbed, dissolved easily or diluted completely by the GI tract. Therefore, to increase the half-life of progesterone and to reduce its destruction by the GI tract, we have decreased its particle size in order to enhance the dissolution and achieve maximum concentrations. So the benefits of micronization is bioavailability of micronized progesterone, similar to that of natural progesterone. The efficiency in the oral delivery progesterone has been accomplished, and micronization of progesterone to particle size of less than 10 in the surface area of the drug and enhances even aqueous dissolution rate from the intestinal absorption. Suspension in oil and packaging in gelatin capsule have been shown to further enhance the intestinal absorption. Now, further, in order to further increase the availability and to make it much more easier for us, we have now introduced the sustained release progesterone, a step further as far as the progesterone is concerned. From micronization, we have also added the added advantage of sustained release. And what is in this? What we have done in this is that we have controlled the availability of progesterone in such a way it is actually in a polymer matrix, and therefore the drug release is timed over a period of 24 hours. Therefore, what is happening is there is a gradual release of the drug, and the levels of progesterone are therefore maintained over a period of 16 to 24 hours. The advantages, of course, of the sustained release preparation are compliance and convenience. There is a gradual release of the progesterone. It makes it convenient to have it once a day because it is eliminated over a period of 18 to 18 hours and even up to 24 hours. And there is a smooth release pattern which avoids a sudden drug release. That means there is no dose dumping. That means you don't achieve a very extremely high level at one time and then it's stuck, it drops. It's not like that. This is the advantage. So basically, now let us see how it is, how it fares clinically, and what is its efficiency profile. There have been some studies which have been conducted from India, like I said, and this is one study which was conducted in 2016 by Dr. Malhotra, Jaideep Malhotra, across 5 centers in India. And what they did was they tried to see the effect of these supplements for luteal phase support. And the result of the study concluded that clinical supplementation with oral natural micronized progesterone sustained release offers therapeutic compliance and alternative strategy to conventional formulations while offering dose convenience and minimal side effects. So another study from Dr. PM Gopinath from Chennai also said of actually confirmed the same thing, because he said that the oral administration of natural micronized progesterone in a sustained release preparation offers consistent tissue concentrations for endometrial support, and therefore a once a day dosage is absolutely convenient and it improves the patient compliance. Also, the slow sustained release kinetics of progesterone in sustained release formulation minimizes drug exposure to liver metabolic enzymes, and therefore it offers a sustained action with minimal central side effects. So these two are very important because of the sustained tissue concentration. The compliance is easier because it's a once a day dose, and also the side effects are minimal. So therefore, with this background, let us see how it fares in the various situations related to pregnancy. So the first one is, of course, threatened abortion. And we all know that in threatened abortion, it inhibits the uterine contraction of progesterone and also minimizes the risk of miscarriage. So, what exactly is threatened abortion? As you all know, by definition, it is the loss of the abortus or the fetus at 20 weeks before 20 weeks of gestation. It may be accompanied by vaginal bleeding or with or without abdominal cramps, and it occurs in about 20% of women during early gestation, and 50% of these pregnancies will abort. And even if abortion does not follow, these fetuses are at risk for preterm delivery, low birth rate, and prenatal death. So basically, anything which is happening to the fetus in the first trimester can carry on subsequently also, and therefore we have to be very guarded about it. Now, what is the role of progesterone in threatened abortion? So high levels of serum progesterone may be protective against early pregnancy loss, which we saw was around 50% in these cases. And the most important predictor of outcome of pregnancy in threatened miscarriage or abortion is actually the progesterone levels. So in a large study of about 1,098 women, in this study from 2008, they saw that with no signs of threatened miscarriage from 4 to 12 weeks, the risk of miscarriage was significantly high if the serum progesterone was about less than 38.3 nanomoles. Now, we in India are actually using nanograms per liter for progesterone, and to convert this, you have to divide it by 2.5. So basically, low levels of progesterone are actually not conducive for pregnancy and will eventually end up. So again, this is a very from 2017, which also is a fairly large study of 360 patients, where they again found that a serum progesterone cutoff value of 35 nanomole per liter was a very useful predictor for miscarriage up to 16 weeks of pregnancy. So remember, divided by 2.5, you can actually calculate what it would be in your own lab. Again, the accuracy of a single progesterone test to predict pregnancy outcome in women with pain or bleeding. This is a meta-analysis of 26 cohort studies and a large number of patients, about 9,500 patients, among which symptoms or an inconclusive ultrasound assessments, progesterone test. That means in 5 studies with 1,998 participants, the cutoff value was from 3.2 to 6 nanograms, and here again it is nanograms was predicted. This predicted a non-viable pregnancy with a pooled sensitivity of 74.6 and a specificity of 98.4. That means a single progesterone measurement in early pregnancy, even when the ultrasound is inconclusive and the patient's symptoms are also not telling you, might help you to decide whether this pregnancy is going to carry on or not. So basically, it is worthwhile looking at the progesterone in these cases. So then, what is the effect of progesterone suppository on threatened abortion? Again, they found that if you give progesterone, the successful delivery is about 80%, and the miscarriage rate fell to 20% from 33%, and vaginal bleeding also was significantly less in the progesterone group as compared to the no treatment group. So the effect of progesterone suppository, therefore, on it reduced the number of abortions, and it also reduced the number of abnormalities related to that threatened abortion, which was found in these pregnancies. That means the bleeding was not there, the growth was better, and all that was found. So again, now in recurrent pregnancy loss, how does it fare in recurrent pregnancy loss? Here again, what you find is that in recurrent pregnancy loss, the endometrial changes fail to develop if the progesterone production is lower than normal. So what is happening is lower than normal plasma progesterone, as we all have seen all along in these slides. What happens is that it leads to retarded endometrial development in the peri-implantation failure, and therefore it may result in a recurrent implantation failure or recurrent pregnancy loss around the time of implantation or very early pregnancy. So, but if the endometrial development is a little better, then the pregnancy can continue for some time and then finish off later on. So these are the hormonal causes of recurrent pregnancy loss, as we all know it. So the role of progesterone is tremendous, even in recurrent pregnancy loss. And this was a very interesting study, which was conducted in 2017, where preconceptional vaginal progesterone treatment was given in patients of unexplained recurrent pregnancy miscarriage. And this study of Ismail is now very well quoted in many of the cases, in many of the other papers as well, basically to find out what is the effect of progesterone if it is started early in the luteal phase in preventing miscarriage in women who have unexplained recurrent pregnancy loss. Because do not know what to do. And the main outcome in this study was to find out what is the miscarriage rate. And let us see what happened. What was the way he conducted this study? And what they did was they divided the design was that 700 patients of unexplained recurrent miscarriage were taken, and this was a double-blind RCT where half of them were placed on placebo and half of them were given vaginal progesterone 400 milligram twice a day. And then the dropouts were also nearly the same, and the miscarriage rate was seen in these groups. So progesterone was started in the luteal phase and continued after the positive pregnancy rate up till 28 weeks of gestation. So this is a very long study where progesterone was started even when the pregnancy test was not even positive. So basically, let us see what the outcome of this study is. So what happened was that in the placebo group, the rate of miscarriage was quite high. It was nearly double that of the progesterone group. Here it was 12.4, but here the rate of miscarriage was reaching at about 24%, 23.3%. So next, what about the live birth and the rate of pregnancy continuation beyond 20 weeks? Again, you find that the placebo group fared badly, about 77.4%, and here the live birth rate was 91.6% in this very difficult group of recurrent pregnancy loss, which is unexplained, where we do not know what is the reason. And here again, the rate of pregnancy continuation beyond 20 weeks was also good. That is why we had such a good live birth rate. So the first trimester vaginal bleeding was considerably less in half of it. The gestational age at delivery was again 37.4, here again significant. And the rate of premature delivery was also very, very significant, halved. And spontaneous and iatrogenic, again, everything was halved. So this is an excellent study to make us understand the role of progesterone in unexplained recurrent miscarriage. So it is more effective than placebo. And now there was a very important trial which happened in 2015, the PROMISE trial, which said that in unexplained recurrent miscarriages, there is no role of progesterone. conclusion of this study was that there is really no role of giving progesterone. However, this latest study by Ismail et al. In 2018 has actually told us that if we are starting the progesterone early in these patients, then it may help us to get them to term much more easier as compared to when we start the progesterone late. So when I first started talking to you, I was talking about the duration of progesterone also. It's not only the dose, it is also how long you give the progesterone that is actually going to help us. So, what are the what are the main differences between the two trials? First of all, it is the time of initiation of treatment, which I said here. This PROMISE trial done by Kumaraswamy was after a positive pregnancy test, and here it started in the luteal phase itself. The therapy duration was only of 12 weeks, and here it was for 28 weeks. And the study design was also different in the sense that they just looked at the pregnancy, and here the cytokine levels were also measured throughout the first, second, and third trimester. So they were looking at the immune modulation that progesterone was doing, and thereby trying to understand whether this is actually the reason why these pregnancies abort. So therefore, this was a very key. This is a key study as far as progesterone is concerned. So this trial, it measured the cytokines levels. It reflected the strong immunomodulatory action of progesterone that may be behind the lower miscarriage rate, and the rate of premature delivery in the progesterone group was significantly lower in this group. The dose used were 400 milligram vaginal progesterone twice daily, starting from the luteal phase and continuing after a positive pregnancy rate test up to 28 weeks of gestation. So remember, it was a long progesterone support which was given in this group in this study by Ismail et al. So the evidence, this actually, it supports the clinical finding and by the laboratory tests. And what happened was that they looked at the cytokine levels and they actually found that there was a significant decrease in the Th1 cytokine, that is IL-2, interferon gamma, and an increase in the Th2 cytokines, that is IL-10, throughout the first, second, and third trimester. So therefore, the pregnancy-friendly cytokines increase by giving progesterone, and the pregnancy harmful cytokines IL-2 and interferon gamma, they decrease, thus making the environment friendly for continuing a pregnancy. So again, to highlight what it said, this study actually told us that the after ovulation, if you start progesterone early, sorry, it actually improves the pregnancy outcome, because maybe it is helping through the immune modulation. So safety. There was another study where the Kumaraswamy study actually looked at also the safety of progesterone, vaginal progesterone, during pregnancy, and actually the neonatal outcomes without any anomaly versus placebo was very encouraging, and they found that progesterone does not lead to micronized progesterone does not lead to any harmful effects on the baby. So, to summarize the effects of progesterone on RPL is we know that it is 3 consecutive pregnancy losses. There is a complex pathophysiology to it. The most commonly recognizable causes are luteal phase defects and immunotolerance derangements. And progesterone actually essentially is an immune modulator for early pregnancy. Women with idiopathic pregnancy loss may benefit from progesterone treatment, and progesterone's role is probably exerted in expression, modulation, and inhibition of various growth factors and cytokines during this period. So basically, we all must understand the major role of immune modulation in pregnancy, and we must understand how these molecules, especially progesterone, help to immune modulate. Coming then to another major area where progesterone is also helping, this is preterm labor and birth prevention, the role of progesterone. And again, what is the impact of a late preterm birth? Let us just first look at that. It is a major problem. We all know it. So it increases the mortality risk by about 3-fold. The increased morbidities are respiratory distress, temperature instability, hypoglycemia, jaundice, attention deficit disorders, increased hospitalization costs, etc. So basically, if you have all this, then definitely it makes a case to decrease these preterm births and not let them happen. So hence, we must look for options which are actually going to decrease the preterm births. So these are the risk factors of spontaneous preterm birth. The non-modifiable risk factors are the race according to the ethnicity, and of course we have a lot of it here in India as well. The age, if the woman is too young or she is too old, poor nutrition, pre-pregnancy weight, low socioeconomic status, absent antenatal care, cervical injury, uterine anomaly, excessive uterine activity, that means the muscle action, premature cervical dilatation, again because of motility of the uterus or increased motility, and then of course an over distended uterus. So all these factors are actually leading to preterm labor. So, how does uh, the reversal of progesterone to estrogen action, again, the action, how does it happen? How does progesterone then act, and how does it help to counter all this? So, the actions of progesterone are it inhibits the cervical ripening because obviously, because its quietening effect upon these tissues of the uterus, it reduces the myometrial contractility, it reduces the oxytocin receptor synthesis in the uterus because I told you it has an effect on the PGF alpha 2 receptors as well. And it also reduces the function of the oxytocin receptor, thereby decreasing the myometrial contractility. Hence, progesterone has a very, very softening or dampening effect on the uterine musculature. So therefore, there is a definite prolonging of pregnancy, and there is an increased survival with according to the gestational age in these patients. And you can see that it is very, very encouraging to see that there is a 99% survival rate in such patients once progesterone is continued in pregnancy. Again, it also decreases the neonatal hospital stay because it decreases the complications. Obviously, if the baby is born at term without any problems, then the hospital stay is definitely going to be less. So, what is the clinical evidence for this efficiency? Again, looking at various studies, what do we find? In this randomized double-blind placebo-controlled study of 150 women with at least one preterm birth who received 100 milligrams of oral micronized progesterone or a placebo twice a day from 18 to 24 weeks until 36 weeks of delivery, the oral micronized progesterone reduced the risk of preterm birth between 28 to 31 days plus 6 days, and the NICU admissions therefore also decreased. In another study, again evaluating the effect of daily micronized progesterone in preventing recurrent spontaneous preterm birth, it was found that micronized progesterone increases the maternal serum progesterone. It was associated with a trend towards a reduction in this preterm birth and an increase in the maternal serum progesterone. So, this second study by Glover et al. In 2011 actually tended to study the levels of progesterone along with the efficacy on the preterm birth. So, therefore, they also found that by giving this micronized progesterone, it wasn't as if it was acting like a placebo, it was actually raising the progesterone levels and causing a beneficial effect on the pregnancy. So, whenever we want to prevent our preterm births, our goals are basically to educate the patient if there is a risk of preterm labor, to recognize early symptoms, and to present for assessment if these symptoms are present, to optimize fetal condition in preparation for delivery, to preserve the maternal health, and to minimize perinatal mortality and mortality. So basically, it is our endeavor that we get out a baby who is in a good condition and does not require too much of help to sustain itself. So neonatal mortality and morbidity is our concern. We want to decrease it. The recommendation of all the various organizations, whether it is the US FDA or the American College or the SOGC, Society of Obs and Gynecologists of Canada, they all have very, very strong guidelines, and their recommendations are basically preterm birth is a major unmet medical need, leading cause of perinatal and neonatal mortality and morbidity, 33% increase in the incidence of preterm birth since 1931, and there is a huge multi-billion cost associated to treating these. So it's a staggering financial and social emotional cost. Again, 17-hydroxyprogesterone, we all know, has been shown to reduce the incidence of preterm birth. Significant efficacy is demonstrated at 37, 35, and 32 weeks of gestation, 33% at 37, 31%, 35, and 39% at 32 weeks of gestation. So these can actually be they are applicable to the race of the mother, number of previous births, and gestational age of previous preterm birth, if there is any. And so, therefore, it makes a case that we should be supplementing these women with more of progesterone. So, this treatment leads to healthier neonates. It lengthens the mean gestational age. It also results in fewer infants below the age below 200, 500 grams. There is a 34% reduction in this kind of low birth weight babies. It reduces the admission to NICU, and it reduces important neonatal morbidities like respiratory symptoms and necrotizing enterocolitis, which we all dread as gynecologists, and of course intraventricular hemorrhage. So it is well tolerated. There is no increase in the rate of complications or procedures, no identifiable risk. Comparable rates of neonatal deaths and miscarriages are very good. So there is no evidence of teratogenicity, and there is no identifiable risk to the child. So to summarize the entire thing, what we also did in one of our studies was that we gave a national epidemiological survey to many doctors, to gynecologists, about 1,000 gynecologists across India, and we wanted to study what are the clinicians' preferences to use this molecule that we are talking about. And what we found was preferential choice of oral micronized progesterone SR in patients of luteal phase defect was about 23%, but about 56% of the doctors were using it for all indications, like preterm birth, luteal phase support, or luteal phase defect. And in BOH, the oral micronized progesterone was the preferred one because it was used by 36%, 36%, and the vaginal route was used by 58%. So basically, it was the micronized progesterone, whether it was used orally or vaginally, this is the preferred progesterone. Similarly, mid-luteal progesterone levels also suggestive of LPD in such cases where they were using micronized progesterone, they were seeing it, and it was found that in about 49 or basically about half of the patients, the levels were to the tune of about 10 nanogram per ml. So in patients who were showing a history of bad obstetric history with short periods, we found that the number of patients were quite a few. And in all these patients, what was the preferred progesterone was the oral micronized progesterone. And many of these doctors or colleagues are using this in order to enhance the results. So the key message is that progesterone needs to be used to support pregnancies. And it is a good idea to get the progesterone and see if it is very deficient. Suppose it is to the tune of about 5, then you really have to give this patient a huge amount of progesterone in order to support that pregnancy. However, if the levels are lying between 10 and 15, the pregnancy will continue but might need supplementation as it grows. So therefore, progesterone levels can actually guide you to how to support the pregnancy. So with that, I thank you very much, and again apologize for the tremendous this thing a glitch in this presentation and my talking to you all, but I'm very happy to take questions from all of you if you have any questions for me. Let me look at my chat box and see if there are already some questions. I would be very happy to answer them. Yes, I can see some questions over here. So I will stop sharing my screen now and I will try to see if I can answer some of your questions. Okay. So Dr. Sumati from Anantapur asks me, do we have to give progesterone SR for low-lying placenta and a bout of bleeding at 12 weeks gestation? Sumati, I would do it. Basically, I mean, it is possible that this could happen because of the contractility of the uterus. And if you go by what I have told you, then progesterone does decrease the contractility. And if you support this pregnancy with some extra progesterone, it might help you to take the pregnancy forward. So I would definitely say that you could add progesterone in such a case where there is. We all know that the low-lying placenta is going to go up gradually as the pregnancy advances, but till the time it is still there, you may be helping the patient. Then Dr. Veena from Trivandrum asks me, what can be the maximum dosage of progesterone SR per day? Again, see, since it is sustained release, and since the otherwise, what is the dosage that we are giving? We are giving up to 400 milligram twice a day, or the normal, not the sustained release, the normal, or we are also giving 600 milligram twice a day. So maximum is what we are doing. But basically, so all said, it is about 800. Here we are already giving about the same dose in a sustained release form. Therefore, one tablet might be all right, but if you think that the progesterone levels are really low, then you could go up to 2 tablets a day. But I don't think you will require more than 2 tablets a day to achieve the progesterone levels that you desire. Manisha Sachar, Jalandhar. What is the role of vaginal progesterone versus oral in IUI pregnancy outcome? Manisha, actually, there is no difference between the vaginal route and the oral route because of the formulation that we are talking about. We all know that the vaginal route has a first pass effect because it is lying close to the uterus. We know that about drug delivery system. But first of all, it is the choice of the patient. If your patient is quite comfortable with the vaginal route, you could give it as a vaginal tablet as well. But the idea of using these tablets, bringing about these changes in the tablets, is that you want to promote the oral route because the vaginal route is not very easy for the patients. Hence, we are saying that you can give her an oral route instead of a vaginal. But as far as the pregnancy rate is concerned, it's going to be the same. There's going to be really no difference because the molecule is the same. It's only the route that is different. Sonia Malik Raza from Mahat. How to proceed for BOH? Is progesterone SR? Uh, See, again, when you are going by evidence-based medicine, you have to have some kind of a proof to say that this is the reason why it has happened. Not only for the patient, but also for yourself. You have to be convinced that okay, if I'm giving this treatment to the patient, it is the correct treatment, and she needs it. You have to justify it not only to the patient but to yourself also that you're doing the correct thing. So if you think that you can get the progesterone levels done wherever you are and you find that they are low, then in that case it is definitely a case for giving progesterone to that patient. However, if we have been talking about, if you want to give it empirically also, as many of us do in ART, many of us are giving progesterone supplements in IVF practice. In that case, you will not be wrong because it may help the patient to buy. The excessive dose of progesterone may not harm her, but yes, it might help her. So therefore, there is actually nothing against it. However, there may be no evidence to what you are doing. So therefore, just be careful on what kind of a patient you are dealing with. Ritesh Kumar Jain, Udaipur. What is the role of HCG injection for luteal phase support? Yes, that is something that I mean, it's a good question, and I think you should be knowing the answer because we know that we are only trying to rescue the corpus luteum by giving HCG. What is the meaning of rescue? It means that we are trying to see that the corpus luteum does not degenerate, and therefore the progesterone excretion or secretion by the corpus luteum continues. If we find that the corpus luteum is weak and the progesterone levels are low, we are actually trying to push it by giving an extra dose of HCG so that the corpus luteum remains and retains its function and continues the way it is. So that is the role of HCG. However, in patients of ART where you have done an IVF and where you are finding multiple corpus luteal and where there is a risk of hyperstimulation, or after an IUI also, if you find that there is a risk of hyperstimulation, ovarian hyperstimulation, your ovaries are very big, then even though you may find that you think you not find, but if you think that the progesterone is low, it will not be, because if you have so many corpus luteal, they will all function and produce progesterone. There, HCG is contraindicated because it is going to give rise to ovarian hyperstimulation syndrome. So beware of ovarian hyperstimulation only in cases where you've done an IUI and where you have had a patient of IVF. There you should not be giving it. But in other patients, yes, there is a role of giving HCG. Devi Jha from Boda. What is the role of progesterone SR in RPL? I think I alluded to that in great detail. This study, which was conducted by Ismail, actually tells us that there is a huge role of progesterone in cases of RPL as well, because it acts as an immune modulator. That is what he has proven. And in addition to that, it has its own hormonal effects that we all know about. So therefore, there is a major role of progesterone in patients where you are definitely finding a low level of progesterone, one, or even if you're not finding a low level of progesterone, if you supplement them with unexplained, like we said, unexplained recurrent pregnancy loss, you may find a benefit if it is started early. They started it in the luteal phase. So if you start it early, then it may benefit your patient. Dr. Sachin Butala from Ahad, is there any precaution needed in using this? No. Progesterone is a safe hormone. It does not need any precaution. Dr. Vivek from Mumbai, how can we check if the progesterone levels are low? Yes, it's a very good question. Progesterone is a very, very labile kind of a hormone. It changes very frequently. Its variation is tremendous. So what is actually suggested is that every day, if you want to do a progesterone level every week, or if you want to do it 3 times during the luteal phase, in order to know whether your patient is doing well and she will conceive or not, or after pregnancy also, if you want to check the patient's progesterone level, and suppose you've taken the first progesterone level at about 9 o'clock in the morning, all your progesterone levels should be taken at the same time, at 9 a.m. So the variation, if it happens, it will be there. More variation will be there if the time is shifted from 9 o'clock you're taking it now at 12 o'clock. Then you may get a different progesterone level. Therefore, whenever you have to whenever you have to check your progesterone, be careful of doing the progesterone levels at the same time of the day whenever you do your levels. I'm not promoting progesterone to be done every day. No. What I'm trying to tell you is if you're going to do it 2 or 3 times in your treatment cycle, you should always be doing it at the same time. Then the levels that you get are going to be nearly the same every time, and therefore, and this is evidence based. There is a paper which tells us that it should be done at the same time. Okay. So, dydrogesterone versus progesterone SR, what would you prefer for luteal phase defect? Well, both the molecules have their own advantages and disadvantages. Like we said, the natural micronized progesterone has its own advantages. It has a beneficial effect on HDL, where the other one does not. But of course, having said that, our primary concern is mainly with pregnancy, and we find that the pregnancy rates are nearly the same in both the kinds of progesterone. So whether you give dydrogesterone or give progesterone SR, it's going to be the same. Progesterone SR is now reaching nearly natural micronized progesterone, I would say, is reaching nearly the same stage as dydrogesterone, but in pregnancy support, if it is a natural pregnancy, then the dydrogesterone dose is 1 BD. If it is an ART pregnancy, the dydrogesterone support, luteal phase support is 1 tablet 3 times a day. Here we are saying progesterone SR is just once a day. So therefore, for the convenience of the patient, again, the convenience is important. So here it is 1 dose, there it is 3 doses or 2 doses. So that's the difference. Otherwise, as far as pregnancy rates are concerned, they are nearly the same. There's really not much difference. I think that is all there is in the question. I don't think we have any more questions. And once again, before I leave all of you, I would really, truly apologize for the problem that this internet connection has created, but it was beyond me. And I hope you will all excuse me for this. But I do hope I have been able to convey what I wanted to tell you. And I do hope that the progesterone, the molecule, which seems so simple to us, which we've been using ever since medical school, I've been using it for 50 years now, is still a very complex molecule. And the more you know about it, the better your results will be. So with that, I'll leave you with some new thoughts on the use of oral micronized progesterone in its sustained release form. So do try to use this new formulation of progesterone, and I'm sure you'll be very happy with the results. Well, thank you very much. I'm signing off now. Thank you very much to all of you.